I would like to welcome to the podium Dr. Maria Garcia, who is Associate Professor of Pediatric at the UCLA School of Medicine. Her expertise is in the areas of pediatric allergy and immunology, and she's the director of the Allergy and Immunology Training Program at UCLA. So welcome, Dr. Garcia.
I was almost thinking my presence here is superfluous because at least the first couple of questions, you're pretty good. So I think we're just going to review. You're going to teach me more than I'll teach you. Thank you very much for inviting us, and with no more, I'll start with my talk. I think at the end of the day, this is what my part of the talk entails is newborn screening. Why do we need to screen first kid? Who? Essentially, the who is one person, everyone, every newborn, and then how. Well, severe combined immunodeficiency, intuitively implies a very severe defect in the immune system that makes you, susceptible to all kinds of infections. So it is a rare disorder, but it's not that rare, as you will see a little bit later. And it's characterized by increased susceptibility to bacterial, viral, and fungal infections, secondary to a profound impairment in both cellular immunity and humoral or antibody immunity. The affected patients usually present before newborn screening with life-threatening, protracted, and/or opportunistic infections in the first year of life. Sooner or later, they will develop failure to thrive, secondary to infection, secondary to the defect itself, and invariably, the early death occurs without immune reconstitution. What causes SCID? This is an interesting, different from other conditions that we screen through newborn screening, is that it's a syndrome. It's caused by many different genes. And largely, for everything that we know so far, that inherited monogenic defects, one gene, one disease. I put here more than 15, but every day is another gene that is associated with SCID, but now, probably as of yesterday morning, maybe there were 20 or 21. So there's a variety of genes involved in the causation of this disorder. And the two things that are very peculiar to SCID is that mutations in different genes may give rise to a similar phenotype. So the kid, both in the laboratory setting and even, from the outside, might look exactly the same, and yet the defect itself be caused by two different genes. The common pathway is that they might affect, T-cell development at somewhere along the line that converges for different gene defects. Conversely, the same genetic mutation may result in variable clinical phenotypes, even in siblings. So siblings that will have genetically exactly the same mutation, one may have a very severe defect and the other one may be not so bad. So obviously there are additional aspects of gene modulation, epigenetic alterations, or environmental exposures that may change the expression of exactly the same genetic defect. So you actually were on the money, you guys, that SCID fulfills the criteria previously established for newborn screening for a variety of reasons. And this was apparent, in the mid-2000s when there was a big impulse to add kids to newborn screening. And these are sine qua non characteristics characteristics of a newborn screening program. The disease itself, it has to be a serious disease. We don't screen, maybe for diabetes, although we could. And definitely SCID is such a disorder. It's fatal, universally fatal, probably by age 1, if, up to 2, if left untreated. It's not detected by the exam because most babies with SCID, they look normal. They don't have anything in their outside that makes them look different from a normal baby. The incidence of SCID is rare enough, but it's frequent enough, and that supports screening. And I have to tell you that, congenital hypothyroidism, the incidence is 1 in 3,000. And we have been screening for hypothyroidism for a very long time. PKU, that was the first disease that was screened by newborn screening, the incidence is 1 in 13,000. Galactosemia that I used to read, when I did pediatrics in my boards, it's 1 in 60,000. And the unforgettable maple syrup disease that some of you might remember from medical school is 1 in 300,000. So, and we screen for all of these diseases. We've been screening for a very long time. For SCID, the estimated incidence before newborn screening was roughly 1 in 100,000. But the data that's coming in from the programs that started, the pilot programs, estimate that the actual incidence is more than 1 in 50,000, so it's not that rare. And in certain populations, like the Navajo Indians, the incidence is very high of a particular kind of SCID, but it is actually a founder effect, so it's very common in certain ethnic populations. The diseases for newborn screening have to have a well-established confirmative testing, because you just say, oh, you have a problem, and then how do I test for it? It would be useless if we didn't have it. And we definitely have both the blood lymphocyte phenotype and function, and the genetic testing now are available universally in the U.S. to confirm the diagnosis. Of course, it has to be a disease that has an effective treatment, because if there is no treatment, there is no use to diagnose it early. And that the treatment early treatment improves outcomes. And that's the case for SCID, that the best survival is when treated before infections occur, like in PKU. If you institute a diet before, the developmental delay exists, it's a huge difference. And the screening is cost effective. And that has been what delayed a little bit the development of the SCID newborn screening until it could get to a point where the additional test, I was a little bit involved in the financials of the economics of this, it had to be under $4 to make it cost effective. And the people that do cost effectiveness, how much life it ends up being that the trick acid that we use now is definitely cost effective. What I wanted to pinpoint here is definitely earlier is better. It is better in terms of survival. This is a table, that I took from the data accrued at Duke University that started treating patients with SCID, 30 years ago. And the survival in patients that were transplanted before the age of 3.5 months is around like 60 to 62%. And when you transplant them before the age of 3.5 months, the survival is almost 100%. So earlier definitely is better. It's not only better, but it's cheaper. If you, this is an article that was done in collaboration between our group and Florida and Cincinnati. Just look at this table, at this part of the figure. If you transplant these babies before 3.5 months, the transplant, that is not a cheap procedure, let's be honest, costs about $300,000, the total cost associated with treating these infants. If we transplant them after 3.5 months, the cost rises to almost $1.5 million. So treatment is better and is cheaper, earlier treatment. This is, as of June of 2015, all the states in the U.S. that are screening for newborn, and you can see you're in the blue, you're in the good part. All the blue states are the ones, I think they're the Republicans? Oh no, those are the red states. But in addition to that, I don't know what you vote here, definitely. And the green states are the ones that they're not even in initiating pilot programs. I did this on purpose. This is part of the questions that come at the end. No, it's not true. This is just the development of the immune system. And the reason why I put it is the SCID affects directly or indirectly both arms of the immune system, of the adaptive immune system, the T cells and the B cells. But the common characteristic and the reason why we have so many problems is because the T cells are affected. You can live without B cells. There is a condition, a primary immune deficiency called XLA or X-linked agammaglobulinemia, where people have no B cells. And they can live happy for a very long time with a little bit of immunoglobulin. If you don't have T cells or your T cells don't function well, you're doomed. So we're going to take that part out because that's not what we're going to focus today. Is our problem essentially in severe combined immune deficiency is the T cell and T cell development. And all of these different stages, is where a T cell goes from being a stem cell to be a lymphoid progenitor and through what we call thymic education, become a fully functional T cells. And if you remember, there is the CD4 T cells that we call helper and the CD8 T cells that we call cytotoxic. All of these names that you have in here, they are either cytokines or cytokine receptors that are important for a T cell to go from a fully unfunctional progenitor to be a fully functional T cell. And you will see later in the talk of Dr. Kuo that all of these either gene products have been found to be defective in different phenotypes of T cells, of SCID. IL-2 receptor and Bragg, and all of this we'll see in a little bit that defects in these genes have been identified as causative of SCID. The reason why I signal this little bit here is because part of what it makes a T cell, a fully active and mature and functional T cell, is the development of the T cell receptor. And I just made it in big here. If you don't have a fully functional T cell receptor, you're not going to live. And the basis for the testing for SCID newborn screening is the process of the formation of the alpha beta T cell receptor. So no T cell receptor, no cells, no T cells. Going back to what we were saying, severe combined immunodeficiency, the hallmark of it is a severe decrease in the number and or function of T lymphocytes. Not always there is no T cells. The T cells that are there, they don't work. And what is very important is that you might have T cells that either are maternal or they are, peripherally, dividing. But what you don't have in patients with SCID is that very low or absent naive T cells. Those are the ones that just were made in the thymus that are ready to fight whatever infection comes along. The way that we test for the newborn screening is to measure what is called T cell receptor excision circles, or TREX for short, that are in the long run are byproducts of the process of making a fully functional T cell receptor, an alpha beta T cell receptor. Both the immunoglobulin and the T cell receptor have this thing of somatically rearranging their bits and pieces of DNA, and in the process of doing that, a little bit of DNA, that is the TCR delta locus, gets cut off. So essentially what we measure with the TREX is this little bit. It's a DNA-based assay, the TREX assay. What it's figuratively put in here is that this bit of DNA that is still, it's episomal, is inside of the nucleus. As the T cells divide, does not divide. So, it is proportional, what we'll see a little bit later, the number of TREX, let me just go here, will be proportional to the number of fully functional naive T cells, but it's not going to be the same number because they keep on dividing later. We'll see in a bit. So how does the TREX assay work? It uses the good old Guthrie card, that is the same card that is used for all the other diseases that we test by newborn screening. From there, we cut a little bit, a very small punch hole. From there, the DNA is extracted, and then by a series of amplifications, the PCR technology has been available for a couple of decades. We are able to measure these bits of DNA that are proportional to the number of naive T cells. There's always a control bit of DNA because it could be degraded. And what I wanted to show you that even if it seems a little bit like sci-fi, the way that it's measured and quantified, because we're only taking a little bit of DNA from a little hole inside of a drop that it travels, thousands of miles, the vast majority of the samples are very good. They're good enough that only a very few of those will require a repeat sample. What does the TREC number mean? Well, what I told you earlier, the number of TRECs is directly proportional to the number of naive T cells in the blood spot. So if you have sufficient, TRECs, you have sufficient naive T cells, and you're probably good. The normal newborn TREC, the number is about 10% of the naive T cell numbers, just for what I told you, not the cells eventually will proliferate in the periphery. And the other thing that is very important is that a zero TREC or a low TREC is not an indicator, is an indicator of T cell lymphopenia, but not a SCID. So these patients, you can diagnose them, oh, you have low TRECs, you have a problem, not necessarily, and we've seen with Dr. Mellish today, two different patients that might have very low T cells. One may have a SCID and the other one may not. On the basis of that, I think that Dr. Moore will go a little bit over this. These days we don't define a SCID on the basis of infection because hopefully we catch them before that. So we usually classify them as typical SCIDs in which after we do the confirmatory test, they have very few T cells in the periphery. And these are the ones that require immediate intervention. There's what we call leaky SCIDs that might have defects maybe in the same genes, but that allow enough naive T cells to be formed and detected in the periphery. And the variant SCIDs, in which they look like SCIDs, they smell like SCIDs, but we can't find the gene that causes it, or they are not exactly the phenotype that we recognize, that may or may not require intervention. So that is more for the specialist. This is something that we deal with, and we have to deal a little bit with uncertainty in many cases. I wanted to tell you that T cell lymphopenia is not always the same as SCID, like I was telling you earlier. There is a number, we've discovered that through the false positive test in the TREC assay, which are syndromes with T cell lymphopenia, especially the chromosomal deletion or duplication syndromes that have a variable T cell lymphopenia. For example, the George syndrome might have, in fact, many of the false positives in the California initial analysis were the George. Chart syndrome, that is a variant, also that have no thymus. We have detected a number of patients with ataxia telangiectasia, and even some patients with Down syndrome, we are discovering that they have low TRECs and peripheral T cell lymphopenia. Secondary T cell lymphopenias, these are T cell lymphopenias of non-genetic causes. Intestinal lymphangiectasia, these are patients that have protein-leucine enteropathy, and they don't, that's typical that they will have low T cells in the periphery. Chylothorax, cardiac abnormalities that might result in some form of protein-leucine enteropathy. And we have found one case of a patient that we think he was lymphopenic because his mother was on Immunodeficiency. Perhaps the most common cause that you will find in a normal setting is the T cell lymphopenia of prematurity. Extreme preemies can have very low T cell count. It will depend, the severity, on the degree of prematurity and if they have no other clinical context, because you could be a SCID and be premature. But let me just tell you, for you to know that even the extreme preemies, the T cell lymphopenia is transient. So for these babies, there is a special protocol where you have to redo the screening and redo the TREC later on. So as you can see very quickly, they go into the normal range, but you might find those. This is the protocol that is used by the Hawaii SCID newborn screening that was provided by me by Oregon. You know that you guys partner with Oregon for all your newborn screening. It's slightly different from what we use in California in terms of cutoff of the TRECs. This is something that probably it's not going to get to you, it's going to get to Dr. Mellis or to the specialist that will receive these patients here in Hawaii. But what I can tell you that state by state, the cutoff and the protocol varies slightly, adapted to the local resources. Okay, so what do you do with the SCID new, if you have a positive SCID? Well, if they confirm the low TREG number, and that's something that people over at Oregon will do, they'll do a phone call to the physician of record. Usually that could be a pediatrician. At the same time, they'll probably contact Dr. Mellish here. But the physician of record, if it is your baby, you should know, because many times it's you, the one that will have to at least get that family from wherever they are and call them back for the confirmatory testing. After that, we do a blood draw for lymphocyte counts and phenotyping. How many lymphocytes they have, how many T's, how many B's. That could be confirmatory. If it turns out that they have very low T's and they have no B's, depending on how that first thing looks, it might already smell like a true SCID or maybe not. If the T-cell lymphopenia is confirmed or they're absent naive CD4 positive T cells, that's when the patient probably will be already in the hands of a specialist in dealing with this kind of patients. And it will be up to Dr. Mellish to consider admission, do a thorough history and physical exam, perform additional confirmatory tests, imaging for the presence of thymus, that's still a good test, good test, and of course the issue of how you counsel the family while they go through the process of ruling out or in a SCID. Which are the confirmatory tests? Flow cytometric analysis, as I told you, that includes lymphocyte test, T and B and NK cells. That many times is a giveaway, for the good or for the bad. T-cell functional studies, we put these T-cells in a little, well, and we see if we can make them work. Because sometimes they're very few, but they work okay. So this is another very important test in trying to rule in or rule out a SCID. And we are able to quantitate relatively simply, the presence of naive or antigen-experienced T-cells. You could do enzyme activity measurements for ADA or adenosine deaminase. Dr. Cohn here will go over the details of that. This is one of the important causes of SCID. And then, of course, eventually we'd like, if possible, to do a genetic analysis to identify the specific mutation, because that seals the deal. If you're going to do either, never mind if you want to do gene therapy, but if you even for transplantation, the more assurances we can have that this is a true SCID, the better. The additional laboratory testing, such as immunoglobulin quantitation, maternal engraftment, they're relatively simple tests to do, or radiation sensitivity. Now, radiation sensitivity, there is a group of kids that are radiosensitive. These are patients, in fact, that if they have this condition, high radiation can injure them. So fortunately, this is more of the Artemis mutation, the small group of SCID gene defects that are associated with radiosensitivity, and we can do this in vitro tests for this. But these essentially are after the very 2 or 3 first things that can be done by almost any laboratory in the country. If we have a suspected SCID, what are the initial management strategies? Protective isolation to the extent possible, breastfeeding only after the mother is confirmed to be CMV negative. That is something that we can discuss a little bit later if you wish. This is very important. If even you smell a SCID, leukodepleted, irradiated, CMV negative blood products for transfusion. Even if there is a suspicion of a SCID, this is crucial, because not giving, CMV positive cell with transfusions can bring CMV to the baby that has no way to defend against itself, and more importantly, non-irradiated blood can cause a graft versus host. So this is, way back in the day, I saw a kid die of blood transfusion because we didn't suspect it. Prophylactic antibiotics should be started. Immunoglobulin replacement therapy, even if they have immunoglobulin, by definition, these patients cannot make effective or protective antibodies. And then the other thing that is crucial is no live vaccine. So if you suspect, somebody told you they have low TREX, don't even think on the rotavirus because this kid is going to get it. So those two, perhaps to me, this and this are the most important. Until the weather clears, don't do it. This is the result of the 4 years in the California newborn screening. I put it on purpose just to show you that at least in California, with the cutoff that we have, 4 out of 5 positive screen or very few traits are not kids. So if you have to deal with one of these patients yourself, one of the family, you say, okay, it may be, but it may be not. So 4 out of 5. In states where the cutoff is higher, it's like 8 out of 10, or more than that, is like maybe 9 out of 10. So in California, it's halfway. Oregon is lower than that, so probably their false positive rate could be even lower than 4 out of 5. They will have to roll it and look at the data in a couple of years and see what that is. So, in fact, if you look at the kids, this one, if you look at the percentage, it's 12 plus 4 plus 3. So roughly 20% ended up being some variety of kids, but 80% ended up being something completely different, and more than half did not have the problem. So this is just for you to realize it's still a very good test, but you have to look at not everyone will have it. The last thing in here is that we learned from these first 4 years of the newborn screening in California is that what we thought, when you look at the case, you look at the Immunodeficiency, that is very nice book, it says that the majority of kids are due to a defect in this gene, the IL-2, the gamma chain, or the H-linked kid. It turns out that it's not half. There's still, there's a high proportion of patients with IL-2 receptor gamma defect, but it's not half. We are discovering more and more the increased proportions of other genes that we thought that were very rare, and we still have about 10% of those patients that we could not identify and still qualify as kids. What the SCID newborn screening misses is not the answer to all your questions or all your problems. Definitely, primary immune deficiencies that can be, very severe for other reasons, but in which T-cell lymphopenia is not a prominent feature. XLA will be, a WAS will be a lot of. It doesn't mean that they have a newborn screening that was normal, that they are not going to have a primary immune deficiency. Combined immune deficiencies that can behave like kids, but the T-cell defects occurs after that PCR recombination, and Dr. Puo will talk a little bit about that. Sufficiently leaky kids that, the gene is not working well, but it's working some, which allow this TREG number to be above the cutoff level, or in which, and perhaps Dr. Cohn will talk about that, there is some maternal compensating effect, and maybe in this case it's an enzyme defect, and maybe maternal enzyme is helping out. And then, of course, the biggest fear is the kid that was not trained because they didn't intend to draw, or that somebody dropped the ball and it wasn't followed up. Okay, so the take-home messages are that the SCID includes a group of genetically determined disorders characterized by profound effects in both cellular immunity and antibody production. The kids are affected by recurrent life-threatening infections from infancy, and almost all die before their second birthday. It's caused by genetic defects that are inherited, but it's important that most kids are sporadic. If you have a brother with H-linked, gamma chain defect is probably in your boy, you might have it. But it's that 80% of the defects are sporadic. It is a treatable condition. People should not die as kids. And the early diagnosis includes outcomes. The other, the T-cell lymphopenia is a hallmark of kids. The T-cell receptor excision circles or effects are directly proportional to the number of naive cells in the circulation. A normal TREG virtually rules out classical forms of SCID. So remember that it might be leaky SCID, there might be other forms of SCID that you might find later in life. Conversely, a low TREC is not diagnostic of SCID. Babies with low TREC should be referred to a specialized center. Confirmatory tests are widely available and should be performed promptly, within, probably a few days of receiving the negative or the positive newborn screening. The initial assessment should follow national standards, and remember always that family counseling and education are key. Thank you.